Give it just a couple more minutes. Dr. Dzau, the other thing for you to know is that many of these boxes are rooms of learners, particularly
Right.
trainees, and other faculty. So there are many trainees on and more people represented than you see on the participant list.
Thank you.
All right, I think I'd like to go ahead and start Grand Rounds for today. Welcome to the Department of Medicine Grand Rounds and Happy New Year, Happy 2024 to everyone. I will say that, at the start of the academic year and then the start of the new year, for our two sort of halves of the series, we always strive to have very sort of special guests and special topics. And today we are incredibly honored to welcome Dr. Victor Dzau to Emory Medicine Grand Rounds, someone who I've certainly looked up to over my entire career. So Dr. Victor Dzau is president of the National Academy of Medicine. He's vice chair of the National Research Council, chancellor emeritus of Duke University, and a past CEO of Duke Health System. Previously, he was professor and chairman of medicine at both Harvard and Stanford. He's recognized globally for a long and highly decorated career as a scientist, administrator, and leader. He's known for his seminal work on the renin-angiotensin system and pioneering research in gene therapy for vascular disease, and his research laid the foundation for a little thing called ACE inhibitors, which we may be familiar with, which, as you know, are used globally to treat high blood pressure and congestive heart failure. Dr. Dzau also serves as the inaugural president, as I mentioned, of the National Academy of Medicine, and he led its transition from the Institute of Medicine. Under his tenure, the NAM has launched important initiatives, including the Global Health Risk Framework, the Human Genome Editing Initiative, the Action Collaborative on Clinician Wellbeing and Resilience, the Healthy Longevity Grand Challenge, and the Grand Challenge in Climate Change and Health. In short, he has put his stamp on really a huge variety of the most wicked problems that I think affect us as physicians and individuals in the world today. He has led significant efforts in health innovation. His vision for academic medicine is to lead transformation of medicine through innovation, translation, and globalization. In 2010, he advanced the concept that we're going to hear, I think, more about today, of the discovery to care continuum, beginning with the bench to the bedside to the population, which has been a widely accepted model in academic medicine, but recently, in addressing significant changes and demands on medicine and society, he has expanded that concept to that which you see in his title by adding society, including the integration of care delivery with population health, and I think near and dear for many of us, addressing social, economic, and environmental determinants and incorporating the important use of data science. Dr. Dzau, it's an amazing honor and privilege to have you joining us today. And I really look forward to hearing about your vision and thoughts. I'll just say that I will help moderate the chat. And at the end, if there's time for question and answer, I'll help facilitate that. So thank you so much.
Thank you so much, Wendy, for that very kind introduction. And it's great to see so many friends on the Zoom, including Carlos and Ravi and many of my friends. So thank you. Let me first ask the question, is this slide off-center? Because to my screen, it is off-center. Not for you. Okay, that's great. So I thought I'll talk about where medicine is going. And of course, in this context, how academic medicine needs to redefine itself in order to meet the needs of today's society in health and medicine. Can I have the next slide, please? So let me first say that what an honor it is to speak to the Department of Medicine at Emory. I've long history with the department, including my good friend Wayne Alexander and many others. So it's really a great honor to speak to many of you. When I think about medicine, most of us think about the Western medicine, kind of leading back to Hippocrates, where we all have taken the Hippocratic oath, which is serve humanity, caring for the sick, alleviating pain and suffering, and of course, importantly, practice medicine with integrity, humility, honesty, and compassion. So clearly, the history of medicine is one of art of healing. And over the years, as you can see in the slide, we have seen, of course, home visit. You can see this painting, which is in the Tate Museum, on a physician sitting bedside of a patient, to home visits, from bedside home visits, as you can see in this American painting, lower to where we are today, because patient-centric approach. Over the years, there's so much scientific advances in medicine that no longer do you have the simple country doctor, but in fact, the emergence of many, many medical specialties. Next slide. So, but I think the ethos of medicine continues to be so important for all of us across the globe, because when you look at what happened during COVID-19, it's very clear that physicians, health workers all come together to tackle this disease, to treat the disease, to prevent the disease, and treat the patient who has the disease, as William Osler said. Therefore, treat the sick, relieve suffering, and really on the front line, patient care is a first priority. And we've certainly done well under this circumstance. Next slide. So when you look at today's medicine, I would say that it's doing, really important things for patients, having individual patients as the highest priority in diagnosing the issues, treatment, and management of the individual patients. In our research, and it's really, really impressive research, so much of our work is focused on the fundamental molecular, cellular, physiologic basis for regulatory function and mechanism of disease. And when it comes to our clinical emphasis, no doubt, and every clinician is looking at disease management, but less on disease returns and little less on social, economic, and behavioral factors. Next slide. This slide shows you that in the past century, medicine has really made enormous advances. If you simply look at the left-hand side, hygiene, sanitation, improved nutrition, vaccination, and of course, reduction in childhood obesity, the mortality, road safety, diagnosis, therapies, really impressive. And to the extent that in the last century, we've seen about a doubling of life expectancy and tremendous reduction in disease burden. HIV, 50% reduction in cardiovascular mortality in the last 50 years, and of course, cancer treatment. Where you're seeing recently is this breakthroughs in, of course, we know about the mRNA vaccine and all the other COVID-19 vaccines, genomics, gene editing, big data, AI, and of course, new ways of prevention and treating disease. Next slide. So all that is really great news, except when you really look at where we are today, you would think that we are on top of many of the health challenges, but they continue to emerge. Infectious disease, more and more emerging infections, non-communicable disease continue to be the biggest disease burden, aging population, climate change, health inequity, to name a few. Next slide. So I think what's the new reality for medicine for science and health is that we really no longer looking at individual patients, but that in fact health is connected to everything. Change our environment, our communities, our culture, where we work, and of course society at large. So communities are more connected than ever. You know that, in terms of travel, in terms of transmission, and in terms of the geographies, but also that there are many social factors which influence health altogether. Next slide. Let me take a step and talk about infectious disease because it's a good illustration of what's going on globally. You can see this trajectory of increasing emerging infections, more and more different outbreaks, because we're having major change in environment, deforestation, urbanization, zoonosis, and many climate change and others that lead to emergence of these infections. Next slide. And of course, what we learn is that we're just not prepared for these continued emergence of new infections. The health system is totally unprepared. It doesn't have enough resource, and we don't have enough sharing of resources, allocation when we're shortage, for example, in PPE and a variety of other necessary health measures. We have workforce shortages, particularly even before COVID-19 and since COVID-19, the shortage of nurses, physicians, and healthcare workers. We have an inadequate public health infrastructure, and where health delivery system, where Emory is doing really well, we don't have enough connection and collaboration between public health and health centers. So health centers continue to treat patients, and public health out there trying to look at disease prevention, and we really need to have much better integration between this. So as the Director General of the WHO says, industrialized countries, we are medicalizing our health, and we lack the human local touch, like countries where health providers go door to door, providing primary care services, looking for warnings of early signs of infection or others at community level. That, I think, is where we're faced with. Next slide. And of course, we all know data is so important. And of course, at Emory, you have collected a huge amount of data, as is Duke, where I come from, as is many other places. But there's fundamentally many registries and data collected, but there's not enough of coordination integration across all the data that's collected. And of course, imagine that we had all the academic health centers data together, we can form a national database. And of course, if you look at the days of COVID-19, how powerful would that be, looking at the trends and the issues? But also, the problem, if you look at COVID-19, of course, is public health. We're so fragmented between state, local, federal, and not having a good data system. And that data system connected with what you're collecting in Emory emergency rooms and your care delivery. So if you put all that together, there'll be a much more effective system to forecast, in the case of COVID-19, for ICU beds, ventilators, protective gear, trends, challenges, community. Next slide. So all that just simply highlights, despite the amazing technology and science emergence, we still have lots of issues. And of course, non-communicable disease is a small part of the issue. The communicable disease is a small part. The non-communicable disease accounts for the majority of disease burden in the United States and globally. Cancer, cardiovascular, obesity, musculoskeletal disease, you name it. Next slide. So what I want to do is take a step back and ask ourselves, as we really have become so effective in new drugs and new diagnoses, we're so good at diagnosing them and treating individual patients, what are the challenges we still face? Well, as you know, they're numerous. High cost of care, disparity in access, a fragmented healthcare system from specialty to primary to community care, weak infrastructure of public health. We have challenges such as maternal mortality or morbidity, death of despair, mistrust, miscommunication, and of course, tremendous issues of social determinants. Next slide. So if you take a look at this alone, our life expectancy, despite what I said, has been really improving. If you look at the right upper corner, the rise in life expectancy throughout what we say United States and comparable countries, we can see it continues to rise, except last 2 years, there's actually a drop in life expectancy. Now that in part is related to COVID-19, but also increasing amounts of deaths of despair, opioid crisis, and of course, health inequities. So even though the past year, the last collected data, we have come back a little bit more, we've not seen it return to pandemic levels. What's really more disconcerting, is the lower two graphs. First, on the lower right, to show that it's income dependent in life expectancy in men and women. That is the high household income, the long life expectancy. And of course, that really is a reflection of social determinants. But the other graph, which is shown in the middle, shows you that even within the same city, zip code matters. That is, there could be as many as a 15-year life expectancy difference here in where you are in your background in terms of Georgia communities. So as you all know, people say zip code matters more than genetic code. All that is really emphasizing the fact that we still have lots of issues to face with, and from individual patients to the socioeconomic condition in which they live. Next slide. So this, of course, leads to social determinants, which you all know so well. But you know, it wasn't that long ago. I would tell you 10, 15 years ago, this was not in the vocabulary of every single physician or healthcare providers. Maybe in public health, but not in healthcare. But of course, we've overall done a good job to recognize, starting from, because Monmouth's work on social determinants. This slide on the right-hand side, the pie graph, is Mike McGinnis, one of the leaders in healthcare, my executive officer at the Academy, where he showed that, in fact, healthcare itself is only responsible for 10% of health outcomes. There is behavioral, socioeconomic, and genetic predisposition. And if you look at the right-hand column, it shows you all the social determinants, where you live, where you work, the food that you take, and the system of healthcare you have access to, and the overall economic and environmental factors. So these are the major determinants that actually greatly influence the outcome of health. Next slide. Now, so you recognize this now. If you look at the survey of US hospitals, most people say, yes, we understand the important social determinants. Look at New England Journal of Medicine. So that means that our role has changed as physicians and as healthcare providers. No longer can we think about the illness itself. We think about the environment and background which the patient comes from. And I know many of you now are asking the question, where do you live? And what kind of job do you have? What can I do? But today I want to say your responsibility goes beyond the immediate patient's socioeconomic background to the entire societal issues, which we want to improve the population health. So I think the refocus will be to help equip you and others to be most useful for most enduring effect, which is understanding how to create a healthier world. Next slide. Okay, so one thing I want to point out is the fragmentation. If you think about what Emory does so well, it's amazing in the middle column, healthcare delivery, specialty care, your cancer, your cardiovascular, your other areas, and ability to really treat people who need them and restore their health, surgery, intervention, immunotherapy, you name it. Of course, there's increasing recognition, such as at Emory, of course, of community and population. So you have a network of hospitals, you have network of clinics, but even then, I think we're not as well connected as we should be in the community, where there's community health shown at the lower level, where there's a whole set of people going directly work with communities, particularly in the global south, where they are not necessarily fully trained as health professions, but they're just there, being able to connect with community, being able to identify issues, and then being able to therefore connect back to healthcare delivery. One project, for example, which is led by Medtronic Labs, which is really very effective, is using digital health. They have community health workers in Africa in many different areas where they just simply visit individual in their home and actually take the information, take their blood pressure, and even, take their bloods, and then connect back to the clinic using digital device where they can get connection of the community with care delivery, and of course, being able to look at long-term follow-up, you name it. Of course, the other thing I want to emphasize is public health. After all, public health, which is out there in surveillance, looking at prevention of illness, etc., collecting data, and of course, having workforce linking service is another factor. So in many ways, these three parallel pathways really should come together in a much better connected way, from public health to care delivery to community health. Next slide. So we at the National Academy of Medicine, and used to be known as the Institute of Medicine, IOM, have written about this for a long time, arguing that primary care and public health should be integrated. That is, that they are frequently carried out in isolation, and the importance of working together to improve outcomes for both sectors. And of course, the opportunities can be spurred by the recognition to improve outcomes, the wealth of data that we're collecting. Therefore, we can share goals for population health together, community engagement as discussed, aligned leadership collaboration, and of course, sustainability. Next slide. We've also called for much better integration of social care and of course, care delivery. Think about this. My mother was very ill, and my late mother, when I needed social work for her, I had to go to a different source of support from her healthcare deliverers, and there's really not good coordination. And the integration of social care and delivery healthcare really affect good teams with data that can really save a lot of time. In fact, Elizabeth Bradley showed in her data that looking at countries as a whole, the amount of money that we spend in healthcare delivery versus social care, we in the United States, of course, are way up there. It's the number one in the cost of care, healthcare, and the least, or somewhere in the lower, in social care. Imagine we spend a lot more money on social care. We won't have to spend as much money in the care delivery side of things. Next slide. So it's very clear that I think the concept of population health needs to be embraced by all of us. From understanding care delivery to public health, community health, and of course social determinants, we look at the concept of public health, population health. Population health is really looking at the outcomes of a group, including different distribution of outcomes for different subpopulations. And of course, it's the health of the entire community, reducing health inequities, providing preventive tools and promotions, and of course, intervention risk factors and adjusted social determinants. So as you know, there's a term that's very popular called convergent science, which is popularized by MIT and National Academy of Science, Engineering, and Medicine, to say that we should bring together all the discipline to solve a problem. In the Lancet paper I wrote in 2018 with Celine Balabat, we recognize that population health is a convergence of science and practice. And I'll come back to that in a little while later. That includes behavioral, social sciences, you name it. Next slide. So finally, I already talked about the integration of data. You can do all those things, but when you have the information, you can really do good design, hypothesis-driven and begin to make changes. So we've seen massive growth in data. You all know this, in wearables, point of care research settings, and where everyday setting. I think the issue is going to be bringing them all together, and for the complexity, diversity, and speed which they collected, and being able to connect them to public health and others to begin to look at the whole range of surveillance to healthcare delivery. And of course, bringing together social determinants, you name it. Next slide. So in that regard, what I want to do now is to say, we recognize that given our 21st century health challenges, today's medicine will have to revisit its fundamental ethos and extend its approach with new partnership and new tools. What do I mean by that? Next slide. Well, C.K. Francis actually wrote in JAMA some time ago, The Medical Ethos and Social Responsibility in Clinical Medicine, in which he wrote, there's a need to balance medicine's devotion to well-being of the patient and the primacy of patient-physician relationship. But they also need to meet the healthcare needs of society. The challenges facing medical profession in the new millennium is to establish an equilibrium between responsibility to assure quality healthcare for the individual while affecting societal changes to achieve care health for all. So I think it says it really nicely. And what I've been setting up is to say, well, we've done really well for science and technology advances and treating individual patients. We failed in actually addressing the large issue of the population. Next slide. So I already said this. We must bring together medicine, community health, and public health. Next slide. Now, so why is it so important to you? Well, first of all, we know that whatever we practice in medicine or research today is rooted in the academic medicine model, because we teach students, we do research, and the model is the Osler model, bench to bedside, and looking at what is the problem at the disease level and what kind of research can we do to address them. But as you think of academic centers, where we really look at the whole issue of research, training, and patient care, we need to start extending beyond the ivory tower, which you have already done so, but many others need to do this to engage with communities and think about how we can use our expertise to help the population. Next slide. So I wrote, as Wendy said, back in 2010, the idea of bench to bedside to population. That is to say, we need to think about what we do so well: discovery research, immunotherapy, gene editing, you name it, to care delivery and translation. Now, at this point, we say we should think about how to engage in the population. That the academic health centers, such as yours, is a system integrator to take that information from fundamental basic discovery all the way to population. So bench to bedside and bedside to population. Next slide. But 10 years later, I started thinking about the changes in the trends. If you think back in 10 years, how we've thought about the issues of social determinants, how we thought about the issues of health inequities, etc. Now, more and more, as we recognize this, we need to go back and look at whether our model is still sufficient or whether we need to define them. And this paper I wrote almost 10 years later, which was published, I think, a year and a half or 2 years ago, I extended the model academic health centers to bench to bedside to publish to society. And let me make my case. Next slide. First, this diagram shows you that traditionally, if you look at what we do so well, discovery translation, we should continue this area of research, which is what Emory is doing really well. Second, of course, we have introduced the idea of health services research, training workforce, and implementation of the discovery translation to improving healthcare. And that certainly is something that academic centers done well. such as Emory. Third is increasingly recognizing social determinants, social behavioral areas, etc., that we need to bring in social behavioral science, looking at how to address the issue of NCD, how to address the issue of social determinants, and work with communities, which is we have begun to do, and that's population and global health. And finally, we need to recognize, of course, the social inequity, the trust issue, the societal implication of what we do, and the economics, therefore society. So now this model has these 4 components. And on the bottom, I showed you what are the kind of driving forces of directions of research and training we need to do in the academic centers, in addition to what's already we've been doing. That's data science, convergent science, practice, equity, diversity, and inclusion. Next slide. So achieve this model, we need to think about 4 areas of emphasis. First, convergence and practice to population health. Second, data science, digital technology, artificial intelligence, and others. Third is community engagement and equity. And fourth is how do we train the workforce of the future? Next slide. So I've already mentioned convergence. Convergence is not just multidisciplinary, interdisciplinary research. It goes beyond that. It's the idea of taking disciplines to bring them truly together to solve a major problem. And this problem for us would be population health. That is, to really solve it, we need to have participation of social behavioral sciences, data and policy, and of course, economic and others all together. And so if you think about what academic medicine needs, is that they need to embrace these new sciences. There are 2 ways to do this. One, of course, is that you're sitting in a world-class university. So take advantage of those departments and schools and university which are doing many of these issues. But I also think that as a world-class academic medicine center, you have to have your own internal core capabilities. So not only do you leverage that relationship in collaboration, but you have to have fundamental expertise in data science, in social behavioral science, in order to make a difference. That, I think, is part of the remit now of academic medical centers. Next slide. In the area of data, you all know how important that is, that data can be used for informed critical care, critical policy making, and of course, public health, hypothesis-driven evidence generation, decision support, and algorithms. So I think every center should build data infrastructure, interoperability, standardization, harmonize the point, and try to integrate with community and public health data. And of course, the data has to be extensive, not only in health, but beyond health, in socioeconomic data and broad data sets. And of course, sharing is absolutely important, and development of artificial intelligence, machine learning, which is now so important in going to the future. And the workforce should be at least trained to minimally know how to use this data and use digital technology. So that's really an important part of and the current academic health center. Next slide. Third is the understanding of equity in society. Because as we understand social determinants and looking at the challenges we face, we have to really understand the upstream determinants are so important. And so what can we do about this? Well, first, you as clinicians and researchers already looking at understanding for the individual patients or their families what they live in. But we also need to look at the importance of relationship between health and society. As I wrote in Lancet, there's no really health equity unless there's social equity. So when so many social policies, things that we do are affecting people's opportunity, they will never reach the health equity unless they reach social equity, which means that we should be looking at policy solutions, at least within our space, in social equity, cohesion, and trust. We have to address misinformation and gain public trust. And I think two other things. We have to look internally at our own structure and operations, that we really believe in equity and diversity inclusion. And finally, as an anchor institution, such as Emory, you hire easily 20, 30,000. I'm not even sure what that number is, of people. You are the provider of care in the community, along with Grady. You are a major economic driver that I think universities and health centers have an obligation as an anchor institution to help develop the community in terms of economics, investing in community, and helping housing, you name it. And very important issue, to be a good citizen of community. Next slide. And finally, workforce for the future. Really important to think about clinician, and of course, clinician scientists that is socially connected and community oriented with skills in communication. So if you think about workforce of the future, we have to start thinking about how to develop fundamental culture and curriculum and competencies in equity. We have recently published a report, Academy, called Creating an Equitable Framework in the Innovation Ecosystem, that talks about training scientists and trainees from day one to think about the question they ask in science, the design they do in research, and the clinical trials of inclusion, all the way to technology transfer. Have we addressed these issues? For clinicians, we need to train them in team science, interprofessional education, understanding of social issues and ethics, and of course, quantitative science. I wrote in Lancet that if you think about our current curriculum of 4 years, I would argue that we should spend more time for our trainees, medical students and nurses, etc., to spend initial experience and exposure to community and social issues, even before you learn to use a stethoscope, so that you know what your fundamental mission is and why you do this. And of course, then that also you need to do that for clinician and practice. And of course, you need skills in communication and data. If you think about this, I think very importantly, the curriculum that we see now in medical school has to change. And the good news, of course, is that we're all hoping that AI can help us change the way we learn, change the way we answer questions, find solutions. As long as AI is done in the proper use and the right safeguard, AI can save a lot of time. And I think that the medical school curriculum should change in learning, in more experience in social issues, all the way, of course, to clinical care, and of course, and many other related issues. So I think that we need to diversify and expand the workforce, reflect communities and population that we serve, and of course, reinvigorate the public health workforce. Next slide. Almost 10 years ago, also, Julio Frank, who's now the University of Miami president, previously the dean of public health at Harvard Chang School, Harvey Feinberg, and Lincoln Chen and others, did a Lancet Commission. The Lancet Commission emphasized the education of clinician workforce to be a lot more relevant to the health system needs. Here it says to train effective workforce education system must be aligned with health system needs. I've added this comment to this really important work. I said, no more than ever, we also take care to be aligned with community, population, and societal needs as well. So I think this is where we are. Next slide. So my feeling is medicine now must extend from the traditional individual patient disease focus to promote a lot more community to prevention aligned with public health social needs. And so I wrote a secondary paper as a result of a lecture I was asked to give the Lancet International Lecture along with the Academy of Medical Science UK. And I said, Has traditional medicine has its day? The answer, of course, is no. Traditional medicine is doing so well, but not enough. So we need to redefine academic medicine to expand our responsibility to include population and society. Next slide. Let me take a minute and talk to you, particularly clinicians and health professions and researchers and the trainees. What does that mean for you after all this? I think what it means for Academic Health Center, for Ravi, for Sandra Wang, for Carlos and others, very clear. And they're already doing this, expanding those areas of emphasis, extending the academic center to be more involved with community, local population. But what does that mean to you? I think you yourself must think about how to address in your day-to-day practice societal challenges in your profession. How to be a major player to address mistrust, misinformation, engage with community, whether it's through your practice or when you have actually time beyond your daily work, to work with community, to develop trust, to be able to be a voice for science and medicine, to honor the social contract medicine and push back on the recent actions that threaten our independence, and to advocate policies that improve social equity. Let me say a few words about each one of them. Next slide. Well, we're all very concerned about misinformation and disinformation. And of course, aside from the fact that there is really bad actors and of course the misuse of social media, I think at the end of the day, it's the trust issue from our community that is beginning to believe in misinformation, disinformation. So we as professions, health professions, must first and foremost understand how to gain trust, and secondly, understand how to communicate. As you can see in the this slide, what I've summarized is some of the work that we've done at Academy to look at how to gain trust and how to address communication. Because the misinformation, mistrust hit at the heart of our professional oaths and our mission. So I think first and foremost, this is what you do every day to your patients, but also engage with community is to listen. Listen first. We don't pretend you know everything. And even if you do, first listen and be empathetic to the concerns of the people in the community. And rather than immediately try to sell and push solutions or have a prepared narrative. I know the answers. You need to get vaccinated versus what are your concerns? Why do you not trust this? And begin to listen to them. Second, of course, is to make sure that our message is going through community organizations trusted by the community and leaders who trust it, like faith-based organizations, churches, and also other community organizations, because it's a two-way dialogue. Third is to understand how to communicate. And I think we do a poor job. We tend to think, well, here's a bar graph, here's a trend line, here's all the data. Let me show you, and you would immediately understand. You understand patients, what their needs and priorities, what they're asking for, and that's where you start your dialogue. And of course, important to understand why the mistrust and the issue of equity, right? I mean, there's a mistrust in community, dating back to Tuskegee and others, and you have to understand they have to trust you and the community. And so how to actually address this is really important. Next slide. Speak up for science and health and equity. Here's some of the statements that we made at National Academy, only selected, for example, when the last administration decided to defund WHO, we came right out to say, you must continue supporting WHO. When there was political interference by Congress and others on peer-reviewed research grants, we certainly spoke up. When there's the climate change issue, when there's so much, certainly last administration, mistrust, we say there's real evidence And then I'd like to talk about the last few ones at the bottom. Next slide. Recently, we have seen a really major increase in actions, judicial and legislative actions that interfere with health system and healthcare. From women's health in Dobbs' decision, I say in every talk I give, National Academy of Medicine and National Academies are non-political. We're not taking political positions. However, our position is the health of the population and how these issues can impact. In Dobbs, of course, you're worried about access, equity, and so many issues that affects us. So we have to speak up about the implication of Dobbs, not the issue of pro-life or pro-choice, but the decision that we need to address. And of course, the tremendous concern, which is now the Supreme Court on mifepristone. In addition to abortion procedures, the anti-abortion pill is now Supreme Court. Huge implications, thinking particularly of women who in fact are in marginalized community, who really needs the kind of help. We have spoken up and worked a lot. We have created a standing committee to address this issue. Preventive care, a Texas judge injunction on the requirement that the Affordable Care Act, that health insurance must cover preventive services. You know, HIV testing, endoscopy, mammography, hepatitis, all this stuff. I mean, this is going backwards in looking at how to do better prevention. So we've spoken up, and of course, that's still very much an injunction to be determined. And more recently, the gender affirming care that certain states are prohibiting, we have to speak up that people must have access, equity to the care that they deserve. So I say to you, our roles and responsibility are in these areas to respond to the threats to health and healthcare. Next slide. That leads to our social contract. Society grants our profession trust and respect, predicated that we draw upon our evidence-based expertise to address the needs of our patients and societies. So next slide, when we need to really meet the social contract, we have to exercise independent judgment and care and participate in regulation of our own field. We have to think about patient welfare above self-interest and financial gain. We have to be trusted experts advising patients and forming policy. And we have to really look at the threats of the social contract, as I discussed, on those issues. And therefore, we must uphold and bolster the social contracts by building trust communities, putting patients first, and looking at our practice autonomy and find ways to policy, to speak up the policy of detrimental signs of health, and of course, formulate policy that can promote health and well-being. Next slide. So my last slide summarizes simply that where we are today. First, we should be very proud of what we have done in science discovery and treatment of illnesses, but it's simply not enough. As the society issues gets bigger and bigger, we must meet the demands of our current world and understand the health challenges of our time and connect it to challenges in community, cultures, and society at large. And with these challenges, we must seek much better integration from care delivery to public health, community health, and integrate into population and society health. And we can do that, as I said, by emphasizing and extending areas, including the 4 areas I talked about. And of course, you as individual providers, no longer enough to focus solely on patient care. Of course, you should when you see your patients, but you also need to challenge the other challenges and honor the social contract medicine. So I think there's the expectation for all of us based on social contract. And of course, we must look at options to preserve trust, respect, and autonomy. So we have a lot of work ahead of us. And I would say, first and foremost, I'm encouraged, particularly as I came to retreat at the Emory Health and Emory Medicine and all the issues that you guys are working on. And I know about Duke and others, you know, we're going to change the tide. We're going to work with all of you together. And that's what I mean by redefining medicine, academic medicine. Thank you very much.
Thank you so much. That was inspirational and gave us a lot to think about. I want to encourage anybody to feel free to raise your hand or put a question in the chat, which I will moderate. I absolutely believe in the vision that you just articulated. But, you know, there's a lot of slip between the cup and the lip, as they say. And I guess I work in HIV and in looking at innovative models of care delivery. And, you know, how do the question is about financial incentives for academic centers to engage in that kind of work. You know, we can talk about implementation science, which often has incredible resources to keep a small number of pilot patients in care that is not scalable at all. If you're really looking at making a community difference or hiring community health workers and so on and so forth. But the financial incentives, I think, are hard for an academic center. So any thought?
Thank you, Wendy. Well, first of all, I mean, we all recognize this is one of the major challenges. And particularly when you look at not only academic centers, but private equity coming in and changing the face of medicine, which is why the good news, at least for academic centers, like yours to say, we will also expand our footprint. We'll also make sure that we have our network of hospitals, and then you bring in your quality, and as we did at Duke and others, and bringing your care quality, but also your patient safety and many issues to upgrade these areas, and you bring in community clinics and others to enable people to do this. This is all good. What you're saying is the way in which right now we reimburse, and the difficulty is trying to balance the budget as you're trying to invest in these areas, right? I would argue that you're right. It needs, of course, value-based care, which of course ACA is trying to move more aggressively. It involves state and also federal changes in the way looking at coverage. And the good news, I know that there are certainly states, such as from North Carolina, when Mandy Cohen was there, the Secretary of HHS, DHHS, she's able to leverage Medicaid dollars and others to cover social determinants. So those are the ways. I think increasingly the insurance companies are getting it too, because the more prevention, the less utilization. So I know for a fact that many insurance companies are supporting social determinants issue. So that's another way to leverage those opportunities. And ultimately, we ourselves need to be a lot more efficient. And as you know, it's been well written that from us and others, that there's about 30% waste. If you simply look at even during COVID-19, the amount of waste reduction, circular economy, there are things that we can do to reduce waste. And of course, in renewable energy, those who have adopted them has found savings from the current waste. So there are things that we can do. But you're quite right. There's a bigger issue of reimbursement and between payers that we need to work on as well. Thank you.
No, thank you. Dr. Thadani?
Thanks, Wendy. And Victor, thank you again. That was fantastic. There were a number of issues you brought up. I'm going to just ask maybe a question on one of them in particular, and that is data sharing. You highlighted the fact that, of course, large academic medical centers like ours, and the ones certainly I've come from and others have come from, spend a lot of time, energy, and effort annotating data and creating large data sets. But as you also alluded to, we're more likely to share data with industry than we are actually with ourselves. And there happens to be a monetary component to that. There's a proprietary component to that. But nevertheless, you know, if we could find creative and innovative ways of actually sharing data with each other, not just for research, but also for implementation, one can imagine that the struggles that academic medical centers have. Not all of them, but at least some of them, we could help each other to solve. What presents sort of the biggest barriers here for that kind of data sharing mindset?
Yeah. So Ravi, it takes leadership. And you being now a leader of a major health center, I hope you would push hard. For example, in the, whether it's AAMC, whether it's AHA, whether it's AAHC, to have your peers come together and say, how can we do better? I think that was an opportunity during COVID-19 where people are a lot more ready to talk about this. And of course, let's make sure we keep pushing for this. But I think your point is really important with regards to what are the barriers. You know what the barriers are, right? I mean, the barriers, in fact, well, it is a lot of work to do interoperability and share, but also it is the issue of proprietary and privacy. And, so it does take leadership to start thinking about how to work on this area. What are your thoughts, Ravi?
Well, I was hoping you were going to help. I mean, like you said, Victor, I think one, it's leadership. I think two, there are ways of addressing the privacy issues. We do it with industry. So I think that's a mechanical issue. And of course, we need resources to do that. But I do think you had mentioned this, I think, at our retreat, and that is ways in which we can actually work together that benefit both parties, and highlighting the fact that, in fact, that is the case, that, in fact, if we got together with Vanderbilt and we could benefit them and they could benefit us. And I must confess, Jeff and others and I have been talking about that, not surprisingly, and I don't mean to disparage, lawyers, but the lawyers have injected their, opinions and have said, there's issues that we have to address from their front, and have, of course, caused us to be much more reticent about moving forward. But I do think Jeff and I are starting to have these kinds of discussions.
Well, I think you just described one pathway, which is don't try to boil the ocean, get a number of your peers to do it together. And second point is to experiment and pressure test. So your lawyers will be there to say there's certain things you can do, certain things you can do. Let's do the things you can do and demonstrate to people that, actually it's interesting. You talk about Vanderbilt. When Mike Johns was active, your predecessor, he and Harry, I'm trying to remember Harry from Vanderbilt. Harry, does anyone remember Harry's last name? And of course, myself and my predecessor, sorry?
Harry Jacobson, Victor.
Yes, exactly. So Harry Jacobson, Mike Johns, and Ralph Snyderman, and then me, when I took over Ralph, we used to meet together, talk about a lot of issues and trying to share ideas. And those days earlier, we were more talking about health system building and also innovation, how to actually together combine some of our innovative power to actually do more commercialization. So I think, Ravi, that's a really good start. You don't need to get everybody on board. You get the major people on board and test out some areas that you are able to do. That would be a strong message and strong leadership, in my opinion.
Thank you, Victor.
Carlos, I think you're going to have the last question.
Yeah, I mean, Victor, this was terrific, and you and I have talked a lot about these issues. I think one of the issues that comes up, you mentioned about obviously the need to change the curriculum, but I also think we need to change. Traditionally, we have thought about physicians as not getting involved in politics, but at the end of the day, it reminds me of the talk that the late Ara de Mora gave in 2020 at ID Week, when she said, all policy is health policy. The best way we can improve health of our patients is by getting involved, by advocating, by going to Congress, by really, and that's a skill we need to learn. We need to learn how to do advocacy, because if we don't, then other people are doing it and we're losing the opportunity to benefit our patients. So what do you think about, the involvement of physicians in politics, which traditionally has been something that we've really discouraged?
Well, like it or not, there are physicians in Congress, which some of them take the extreme other positions, etc. So I do think we as a collective voice ought to be making our voice known, and organizations that represent many of us should, and it really happened in many ways, AMA and others are doing it. But I think when we talk about more on social policies, you're right. I think you all know that we can do this at NASEM because of the charter. But I think as physician groups, absolutely, I'm not suggesting politics, I'm suggesting policies. And you're quite right. I think we are a strong voice and we should be able to be heard.
Thank you.
On that note, we are at the top of the hour. I want to thank you so much for this really amazing chat and for your address and really pulling together, I think, again, so many values that we hold dear and a vision for the future of medicine that I hope that we can rise and meet the challenge.
Well, thank you for inviting me. It's a great honor and I have great respect for your organization.
Thank you.
Ciao.